Hi, in this section we'll cover the association analysis. Data preparation included transformation from long to deep, from one record with an ID and several diagnoses to multiple records with ID, diagnosis, ID, and diagnosis. In the process of this transformation, we removed any missing diagnosis or invalid diagnosis. Also, part of the data activities, we reduced the data to include only those records with IBD or IBS in any diagnosis field. If we look at the taxonomy involved in this association analysis, we found through experimentation that the level of using Crohn's, colitis, and IBS diseases worked the best. So instead of using the individual ICD-9 codes, we replaced those codes with text that indicate Crohn's disease or colitis. We partitioned our data into training, validate, and test. We set our minimum confidence level to 35% and minimum support to 0.6. And we use these levels based on the information in Yang and Logan's paper when they were modeling rules associated with a certain type of hernia. From the results, we looked at the rules with CD, UC, or IBS on the right-hand side, and we considered rules that appeared in both the training and validation results. The test set at only 20% did not create very many rules, so we're considering rules that appeared in both train and validate, and we're looking at the left-hand side of the rules. We're trying to find relationships to CD, UC, and IBS, so we're looking at the left-hand side of the rules. Here we see the results for the top 10 rules associated with Crohn's disease, and this is in descending order of support. Next are the top 10 UC rules, then the IBS rules. These rules cover different body categories: digestive system, respiratory. We'll take a closer look at what the rules had in common or different in this next slide. Common symptoms were abdominal pain, fever, those related to bowel movements, dehydration, and weight loss. We also found common rules for gastritis, reflux, and asthma. Those were unexpected and not found in patient information. Let me stop and say we went out and looked at patient advocacy groups and found what were the conditions or diseases that went along with IBS or CD and UC, and used that domain knowledge to help us evaluate the left-hand side of the rules that we found. The difference between IBS and IBD we found in our rules and in the documentation was the malabsorption conditions, the anemias, the low potassium, that can result from having the IBD disease or because of the medications you take to treat the IBD disease. If we looked further at Crohn's and colitis to see what differentiated them, we found that Crohn's disease had related conditions of abscesses, fistulas, fissures, and intestinal obstructions. Ulcerative colitis had conditions of hemorrhaging, cholangitis, which is a liver bile duct condition, C. diff, which is an infection, pancreatitis, and tachycardia. We took these results, these left-hand sides, and used them to create variables related to those ICD-9 codes. We created the variables and we called them C with the ICD-9 code number, just so we could map them back easily. Then we took these variables along with the demographic variables, the disease staging or severity variable, and the age-cut comorbidity variables, and used them to do some predictive or classification modeling. Those variables were the independent variables, and the target variables we did modeling. We modeled 3 different targets: UC, CD, and IBS. In each case, we partitioned the data, and we had 4 different models that we tried. Here we see the decision tree, gradient boosting, MBR, which is nearest neighbor implementation, and logistic regression. We used stratified sampling so that we would have equal percentages of target variable yes and no. So we would have data for UC patients and those who did not have UC in order to perform the predictive modeling. Here's the model assessment or comparison for the Crohn's disease. In each of the cases, for each of the target variables, the decision tree had the lowest test misclassification rate, and those rates ranged from 0.27 to 0.29. For CD, the important variables we found included ICD-9 codes of anemia, pancreatitis, anemia related to hemorrhage, and dehydration. For UC, the important variables of ICD-9 codes related to blood in the stool, a variety of anemias, the cholangitis, electrolyte disorders, asthma, and the C. diff infection. IBS ICD-9 codes that resulted including the reflux, functional digestive disorders, and a comorbidity of drug abuse. So to review the association analysis, what conditions were common to all were the digestive conditions, especially the bowel movements, weight loss, and abdominal pain. Those that were common to all but weren't found in patient information were asthma, reflux, and gastritis. Conditions that occurred in IBD but not IBS were malabsorption, those anemias, low potassium, low sodium, bleeding or hemorrhaging, and the abscesses. So that's how we could help to differentiate between those with IBD diseases and those with IBS disease. When we took a closer look at IBS, we found that those patients had headaches and migraines, and those didn't appear in the IBD diseases. That's the summary of association analysis.